All right, so today we're going to be talking about your adrenoreceptor blockers, which include your beta blockers and your alpha blockers. So this is just a quick overview of some of those drugs that are commonly used in cardiovascular research as well as medicine. Your beta blockers in general operate by having a negative chronotropic effect, that is, they decrease heart rate, as well as a negative inotropic effect, that is, they decrease contractility. They can also decrease the vasomotor tone via reduction of your angiotensin II. One of the important things to know about beta blockers is their side effects. Important side effects include hyperkalemia, sexual dysfunction, particularly in men, nightmares, and the fact that acute withdrawal of these drugs can increase sympathetic activity. It's also very important to note that you should not use these beta blockers in decompensated CHF or in patients with bradycardia, particularly sick sinus syndrome. We're just going to go over a few of the most common beta blockers, particularly those you will see in practice. So propranolol is a very common beta blocker with trade names of Inderal, Hemangliol, Inopran. The mechanism of action for propranolol is, of course, that it's a beta blocker, but in particular, it tends to be a non-selective beta blocker. That is, it's acting on both beta 1 and beta 2 receptors. It also tends to inhibit renin secretion, so it can have effects on things like angiotensin and aldosterone as well. Therapeutic uses for propranolol include things like arrhythmias, acute MI situations, hyperthyroidism, open-angle glaucoma, and a variety of other situations where you might have hypertension. Side effects of propranolol include bradycardia, cardiac failure, hypotension, bronchospasm, that's due to its effect on the beta 2 receptor, fatigue, and an increase in plasma lipids, as well as the other side effects we talked about in general for beta blockers. Metoprolol and Atenolol are two beta blockers that are selective beta adrenergic antagonists. So they tend to be more selective than some of the other beta blockers. Their therapeutic uses are similar to propranolol. However, they may be more beneficial in patients who have asthma or diabetes or peripheral vascular disease. That is, in patients who you don't want the beta 2 receptor or the beta 2 receptor to be affected. Side effects of beta blockers include the same things that we've talked about. It's important to note that metoprolol is metabolized through the liver, whereas atenolol, though, it goes through the kidney. Esmolol, otherwise known as Brevibloc, is another selective beta 1 blocker. It is very rapidly metabolized, so it goes through the system very quickly. Typically, you're going to use esmolol in emergent situations like hypertensive emergency or also in management of perioperative hypertension. In addition to this previous beta blocker side effects we've talked about, esmolol also has a risk of hypotension, some nausea, as well as dizziness. Now, there are other beta blockers that also have some alpha blocking activity as well. These include labetalol, carvedilol, and nebivolol. So these beta blockers, again, act both on the beta receptors, they're non-selective, but they also can have effects on alpha blockers, causing vasodilating effects. Therapeutic uses for these types of beta blockers include pheochromocytoma, hypertensive emergencies, CHF, and preeclampsia. Important side effects are similar to those that we've already talked about, but it's important to note that nebivolol, of all of these, actually has the fewest side effects. So if you want to use a drug that kind of has this beta blocking activity as well as some of the alpha antagonistic effects, nebivolol should be your choice. Moving on to alpha blockers, these tend to be your zosins, things like prazosin, terazosin, and doxazosin. They are selective alpha-1 antagonists, causing relaxation of the vessels and otherwise causing more compliance of the vessels. Generally, we're not going to be using these for monotherapy for hypertension. You might use these in a hypertensive patient with BPH because it can be beneficial for BPH individuals as well. The important things to know about alpha blockers like these are the side effects. So salt and water retention can happen, so you might want to administer these with a diuretic. You also might see mild dizziness, headache, sexual dysfunction, as well as edema. In addition to your alpha-1 blockers, you can also have alpha-2 agonists. Remember, alpha-2 receptor is a presynaptic receptor, and so when you stimulate this receptor through an agonist, you're actually going to get a reduction in the peripheral vascular resistance, that is vasodilation, in the periphery as well as the kidney. There is no direct action on the heart with your alpha-2 agonists. Methyldopa is obviously one of these types of alpha-2 agonists that you're commonly going to see. Therapeutic uses for methyldopa include hypertension, especially during pregnancy. You're typically not going to use it as a monotherapy. You might use it as an add-on therapy if, your ACEs, your ARBs, your diuretics aren't working in hypertension. But primarily you're going to be using methyldopa and alpha-2 agonists for pregnancy-related hypertension. The side effects of methyldopa include sedation, nightmares, depression, vertigo, and hemolytic anemia. Clonidine, or catapres, is another alpha-2 receptor agonist. So again, it can cause vasodilation. Some of the therapeutic uses for clonidine include hypertension, migraines, anxiety, panic attacks, and in some cases can be used for cancer pain. An important thing to know about clonidine is its side effects. Note that it can cause sedation, dry mouth, constipation, as well as erectile dysfunction. Perhaps the most important thing, though, to know about clonidine is that you need to discontinue it slowly to avoid a hypertensive crisis. Never just abruptly stop clonidine. You always want to discontinue it slowly. So thank you for listening, and I hope you tune in next time.